Fabulous. We can hear you perfectly. You should have presenter rights now or very shortly. I want to thank you again for joining the webinar, and I will turn it over to you.
Sounds great. Thank you so much, Casey. I appreciate it. Well, it is a pleasure to be here. Welcome, everyone, on this morning or afternoon, depending on where you are. It's really a pleasure to be here. A lot of my work focuses on the etiology and neuroscience of autism, all coupled with an understanding of the diagnosis of autism. As well, as the Director of Clinical Services, I'm quite involved not only in diagnosis but also with service provision. So it's very exciting for me to be able to talk about my interest in kind of what science tells us about interventions with everyone here today. So just to start, I want to briefly just highlight, if I can move my slide. Let's see if this works. All right. Presenter rights aren't quite here yet, but I'll get started in a moment. Just want to highlight that I have no conflicts of interest to disclose. All my funding comes from either National Institutes of Health, Simons Foundation, or Autism Speaks, as well as just income from sale of my book and some consultation I do with the Science Channel as a neuroscience consultant. Okay. Let's see here. Let's see if I can.
Just 1 second. It seems to be that presenter rights is freezing, so it says it's passing. Just give 2 seconds.
Perfect. No problem. No problem. So what I'll do today, I'm excited to just talk about interventions in autism from a sort of scientific perspective. What does the science tell us? And so what I'll start out by doing is really talk about the terms that are utilized and clarify some of those terms. There are so many terms that are thrown out when we talk about autism interventions, and many of them refer to the same thing. It gets very convoluted and confusing. So I just want to highlight some of that to start. And then I really want to delve in to say, well, what does the science tell us about autism interventions? What do we know? Then I'd like to move into discussion about how we think about new interventions or interventions that are presented to us, whether they be from a provider who suggests a new intervention, or from a friend or family member says, hey, I heard about this. What do you think about this as an intervention approach? Just want to provide some guidelines for how to think about that. And then kind of end with what can we expect in the future? What can we expect to be learning about in the science and the media over the next 6 to 18 months in terms of interventions with autism? So kind of a sneak preview of what the upcoming science will be telling us. Great. Okay, so moving right along. So again, no conflicts of interest to report. Highlighted what we'd be talking about today. Again, clarification of terms initially, then what science tells us, and then really want to talk about how do we think about new interventions? How do we evaluate them? How do we make sense of about new interventions when they're presented to us? And then what will the future hold? So interventions for autism. Let's see. So this next very complicated slide lists most, but not even all, of the interventions that are out there for autism. So if you simply Google interventions for autism or autism intervention, you get over 5 million hits. This morning I just checked. It was 5,230,000 hits according to Google in 0.23 seconds. So pretty fast. You can have a million different websites, or 5 million different websites, telling you about interventions with autism. And many of these websites will refer to many of these interventions listed on this very complicated active slide. And so the point of the slide is really just to highlight there's a lot out there and it gets very confusing. The way I've sort of organized the slide is in the left-hand column we have interventions that are part of the psychoeducational approach. In the middle and top right columns are interventions that would be termed as complementary or alternative according to the medical community. And then in the bottom right, I've combined a whole slew of psychopharmacological approaches into a little tiny space there only because I ran out of space. We could fill up a whole other page with all the different pharmacological interventions that are available if we listed out each different type of medication that's been prescribed. So let me just talk a little about some of these interventions. So we have many different models of intervention. But what gets extra confusing about these 5,230,000 website pages is that a lot of these terms that are used represent multiple different approaches. So I thought I could talk about some of these right now. The first would be early intensive behavioral intervention. So this term originally came to mean any intervention that used discrete trial training, or the LOVAS method that was originally developed with school-age individuals or young adults. EIBI, or early intensive behavioral intervention, was used to represent any of those discrete trial training or LOVAS method approaches for use with children under 5. It's certainly come to mean a lot more in the time intervening between the 60s and now, to also include really any ABA-based method that is utilized for children under 5. So I think that becomes a little bit confusing just as an initial term. People talk about EIBI, and it gets conflated with the original terminology, that is discrete trial training for young children, to any type of behaviorally based model. So just want to highlight that. And when I talk about the LOVAS method or discrete trial training, what I'm talking about is that method that originally started in the 60s. It was the first behaviorally based intervention that was proposed for autism, and it was the first method actually develop and show some efficacy for effectiveness for actually treating autism, improving cognition, and improving adaptive behavior, and improving language. So this discrete trial training approach, this LOVAS method, is based on behavioral principles. It's based on ABA. And so it became synonymous with ABA for a long time. But really, the term ABA has nothing to do with autism, but really simply has to do with behaviorally based treatment methods, which could be applicable for any type of behaviors. But again, because of that close connection with the LOVAS or discrete trial training method being the first method to utilize ABA principles for autism, they became almost synonymous. And really, when we talk about ABA, really what we're talking about is just a method where the focus is on understanding the environmental events that interact to influence behavior. So any sort of ABA-based treatment is going to focus on understanding the setting in which a behavior occurs and the motivations for that behavior. And to better understand the motivations behavior, you need to really understand the antecedents, those things that happen right before the behavior occurs, and the consequences, those things that happen right after the behavior occurs. And so any intervention that's based on ABA, whether it's used for autism or for any other type of behavioral presentation, what would be conducted would be a functional analysis of behavior where the setting and motivations are the role in setting and motivation in behavior is understood by understanding antecedents and consequences, and then if you understand that, then a comprehensive program can be developed to intervene to modify that behavior. And that's really what all ABA is about. And it just so happens that the 5R LOVAS at UCLA in the 60s said, hey, let's go ahead and use this to work with behaviors with autism. So there's a number of other ABA-based models that get utilized quite a lot, not only this discrete trial training or LOVAS method. Two of the more common methods that have been utilized more recently are the Early Start Denver model and pivotal response training. I'll talk about all three of those ABA-based models in just a second, real briefly. The other sort of common terms that represent multiple approaches would be social skills training. Certainly that's kind of become a hot topic over the past few years in understanding how we're going to intervene and help out both young children with autism, but also those individuals with autism who are getting a little older and for whom ABA-based methods may not seem quite as appropriate because these are kids who are doing pretty well, but really are struggling just with that social aspect of interaction. And again, a number of different types of social skills approaches that are out there. Again, I'll talk about those in a moment as well. Similarly, complementary and alternative medicine is a term that refers to a lot of different type of approaches, and that term itself is really based on the medical model, which is to say there's medicine based on medications you can utilize, and there's a whole bunch of other medical approaches that might complement or be alternatives to this medication intervention. So that's a term that really comes out of the medical model, but refers to a lot of different types of treatment interventions. Actually, the vast majority of treatment interventions that have been reported to play a role in autism. Also, it's the group of interventions we know the least about. Again, I'll talk about that more later. And sort of again, the last type of term is to talk about pharmacological interventions. Seems pretty self-explanatory, but really we're talking about medication interventions at this point, and there's a lot that are out there that I'll talk about briefly, some of them. moving along here, let me just talk a little bit about some of the more common comprehensive ABA-based models. So the first one I talked about, I highlighted already, the Lovaas method, or discrete trial training, or DTT. So 3 different names, all mean the same thing. DTT, discrete trial training, Lovaas method. Already gets confusing. And really, kind of some of the tenets of this approach would be that you're taking any skill, and you're going to break it down into smaller parts, and you're going to teach those small parts, those sub-skills, one at a time through repetitive rote training, and over the course of time, you reduce those prompts, you fade away your prompts, and you shape that behavior until the behavior has been mastered. You do this all in the context of specific trials in which you collect data after each trial to say, did the child complete this skill appropriately? Thereby, by collecting all this data, you can actually determine, oh yes, indeed, the child has mastered the skill. You can then move on to the next sub-skill and work on this set of skills. So an example might be, for a particular child, maybe the issue is nonverbal communicative behaviors. We're going to focus on those skills. So you might break that down. Okay, or we're going to focus on eye contact as our initial skill. So then in the DTT method, what might happen is, seated in a kind of a quiet room without any other distractions, having the child seated at a table, you would say, oh, it's time to make some, look at my eyes. And the child looks at the eyes, the child's rewarded. Again, in the DTT model, that would include reinforcement of maybe a goldfish or a M&M, as it was originally developed back in the 60s. And also in the 60s, if the child did not complete the skill, there would be some sort of punishment associated with that. That is since changed over the course of the past 40 years. But once the child, then you collect data. The child, in fact, made eye contact. We provide a reward for it, and then we go ahead and do that. Once the child's demonstrated mastery, that could be, depending on the child or depending on the behavior, it could be 5 consecutive appropriate responses to the prompt. They say, great, child's mastered the skill. Let's move on to the next one. That was kind of the way discrete trial training originally started. It's certainly, again, over the past 40 years, developed and morphed and changed and advanced to be administered in the home, to be, again, also, as I mentioned, to remove the notion of consequences and to really focus on the reinforcement of those behaviors. The reason for moving discrete trial training from the university-based setting, which was really originally developed, into the home, was because of the notion of generalization. And that is, we've known for a long time that many individuals with autism, when a skill is developed, that skill, it's hard for individuals with autism to translate that skill to other settings. And that's actually what kind of drove the development of some of these other comprehensive models, things like the Early Start Denver model or pivotal response training, or PRT. The Early Start Denver model is a comprehensive ABA-based model, which is also considered to be a naturalistic and developmental approach. And the naturalistic, talking about naturalistic approach, is to refer to the notion that all the training and the behaviorally based responses are supposed to happen in a naturalistic setting. So that is when the child's at play, when the child's having dinner, when the child is brushing his teeth, getting ready, or her teeth, getting ready for bed. And the idea is that will increase the notion of generalizing skills. So skills can be learned in a variety of contexts and then can be utilized in a variety of contexts as opposed to in the UCLA treatment room. It's also, the ESDM is also considered a developmental model, and that is the notion that with a developmental model, the focus is on addressing skills that are developmentally appropriate for a child. And in particular, the focus for the ESDM model is to start focusing on a child's affect. So, and the idea here is, if a child's happy and really excited and engaged with the trainer, with the teacher, then that's going to reinforce this whole notion of social interaction. So focusing on making sure the child's having a good time in the interaction, utilizing and engaging activities that then make it all fun for the child. Again, the idea there is we're then reinforcing the notion of, wow, engaging with someone socially it's pretty fun, it's exciting, and I enjoy it. As well as a particular focus on a child being able to attend. Of course, if there's difficulty with attention. It's hard to really learn anything unless you've got that foundation, as well as child's arousal. If a child's very so overly aroused by experiences, then it becomes very difficult for the child to attend or recognize that he or she is having fun in that social interaction. Similarly to the discrete trial training method, there's also a lot of data collection that is involved. Again, the purpose there is to make sure that has a child mastered the skill or not. With all these behaviorally based methods, the notion isn't just if the clinician says, yeah, I think Joey's got it. Yeah, I think so. Let's move on to the next one. Is to say, I've got demonstrated data here to show that in fact that Jill can do this skill. The third model that's behaviorally based, also naturalistic, would be the pivotal response training approach. Here again, using behaviorally based principles, the idea really is that with PRT, the focus is initially on two what are considered pivotal behaviors. That is, the child's motivation and how that child responds to multiple different types of cues. The thinking is by focusing on those two first pivotal behaviors, what is motivating to the child, what's exciting to the child, as well as can that child respond to sort of different aspects of the same thing, the sound, the visual cue, can respond to multiple different cues. By changing those initial two pivotal behaviors, then all those sort of behaviors will improve. And again, similar to the other ABA-based models, there's a lot of data collection that goes on to verify that the child has mastered the skill before moving on to another. And there are many other types of ABA-based models that are, again, sort of meet the sort of comprehensive early intensive behavioral intervention approach, and I'm sort of adapting that because that's the way we use that term nowadays, EIBI, to kind of refer to any ABA-based model nowadays. So, but let me talk about some of these other types of general approaches that are used. So, social skills training. This means a lot of different things. It means social skills, a focus on developing and teaching social skills in kind of a rote sort of way in multiple settings. That could be happening in a clinic, at home, at school, in different types of formats. It could happen in a group setting. It could happen just with two peers and a therapist or a clinician. But there's also multiple approaches. Social skills training groups could be led by a therapist, or groups could even be led by other peers, typical peers. So many different approaches. They also could be parent-led or have parent sort of parent accompaniment. So a variety of different approaches that can be used when we talk about social skills training. But in general, what social skills training is about is where there's a therapist or a trained peer who teaches a skill, whatever the skill may be. So for example, we're going to work on eye contact today, and what the therapist or peer would do would be to provide concrete reinforcement every time the individual uses that skill in the session. Provides concrete reinforcement, might be with points or star or sticker or Cheerio or whatever the reinforcer is for that particular child, and then highlight then the natural contingencies at the same time. So, hey Joey, I saw that when you looked at Jill, she was so excited she smiled right back at you. How great is that? You get a point for using your eye contact. All this happens in the context of sort of generally fun activities. So initially, the therapist and the group or the two children might develop the rules for that particular day. Again, if it's eye contact, we don't have clear rules about eye contact that are concrete, that are appropriate. So when I want to speak with someone, I need to make eye contact first. I need to make sure they are looking back at my eyes before I start speaking. And then we would practice those skills using those rules in certain fun games like conversation pong, which is, and there's a bajillion of these types of games, but just use a couple that get used regularly. Conversation pong is where you imagine a conversation like a ping pong table, and so the kiddos get to act out a ping pong game through conversation. Or conversation bridge, where you set up an actual physical bridge in the room, or maybe do it on a playground or what have you. And in order to get by your partner, you've got to ask a question and wait and respond probably to another question before you can pass on the bridge. Other fun games are things like emotional charades to focus on understanding emotions, and really the list goes on of possible fun activities that focus on teaching skills that are involved in social interactions. So again, social skills, another intervention that really means a lot of different things and has just a variety of different approaches. So when talking about complementary and alternative medicines, again, this is just that list from that original slide I showed you. Again, complementary alternative medicine, that term is referring to, comes out of the medical model, which just refers to approaches that are not behaviorally based or medication based. But even within this medically defined subgroup of approaches, there's a variety of different types of diets and supplementary approaches, as many of us know, a variety of different animal-based approaches, physiological interventions. So even within this big, larger group of CAMs, there's a number of commonalities. And again, I'll talk a little bit about CAM shortly. Lastly, I just want to touch base on, again, the pharmacology aspect. Number of different medications that are utilized, and I've sort of broken them down into major categories that are used. So one of the primary major categories are antipsychotics, and these are medications that were originally developed for use for individuals with psychotic disorders like schizophrenia. Subsequently, they've been adapted and utilized in individuals with autism, and actually a couple particular antipsychotics have demonstrated real clear market efficacy in reducing particular behaviors for individuals with autism. So these aren't being used, these medications aren't being used to treat autism itself, but simply some of the associated behaviors. Specifically with antipsychotic medications, they seem to be most helpful with reducing aggressive and self-injurious behavior for individuals with autism. There are marked side effects, and I'll talk about those in a moment as well. Serotonin reuptake inhibitors, that's another class of drug which includes a large number of different types of medications. These are predominantly used for individuals with anxiety and depression or obsessive-compulsive disorders. They've been adapted for individuals with autism and are quite often utilized for teenagers with autism. What we know is that literature is starting to suggest that many teenagers with autism have an increased risk for affective disorders like depression or anxiety. And so we see a large number of these medications utilized for treating those type of associated behaviors. It's, again, not treating autism itself, but treating related challenges that certainly impact an individual and family's experience and quality of life. Other types of pharmacological approaches are medications that are used to address hyperactivity or impulsiveness. So that could be either naltrexone or other stimulants such as Ritalin. Again, these aren't treating autism itself, simply treating the hyperactivity and some of the inattention that we, not always, but sometimes see in individuals with autism. Lastly, mood stabilizers are another class of medication that are originally utilized for managing seizures or managing bipolar disorder. They've been utilized, again, to help out for individuals with autism. Again, not treating autism, but treating any sort of lability or mood variation, mood fluctuations for children with autism. So that's just I just want to highlight some of those original big terms that get utilized. We hear a lot, we read about them, we hear about it in the media. And just want to highlight what really they mean, what they're referring to, and kind of convey the I just want to convey the complexity of that and sort of and understanding that. So, what does science tell us, though? Well, first I'll talk a little bit about behaviorally based models and what science has told us what seems to be effective. What are the parts of a successful program? So, with early intensive behavioral intervention, we know that a comprehensive curriculum that focuses on a number of different behaviors, certain number of different skills, things like attentional ability, imitation skills, focusing on language, play, and how to interact socially, that is an important aspect of a successful program. Successful EIBI is not going to, we're not going to see a lot of success in a program that's simply focusing on one of those aspects. It really needs to encompass all the different aspects that contribute to a child's development. It's important for EIBIs to be sensitive to the normal appropriate developmental sequence. We talked about that in relation to the Early Start Denver model. Again, all of these models are going to be based on ABA principles, so behaviorally based, where there's going to be data collection actually to verify that a treatment, that the approach is working or not working, so they can be modified. Additionally, it would be important for there to be specific behavioral strategies that focus on disruptive behaviors. Disruptive behaviors can, as we all know, can really throw a monkey wrench in our day, but also in our educational experience. So making sure we're addressing those disruptive behaviors as they come up and having a strong behavioral strategy to address those as part of the program is going to be critical. Parent involvement is an absolute must for a successful EIBI program, as well as the either the implementation in a naturalistic environment or a transition or a plan to move from a highly structured, highly supported environment into a more naturalistic environment. It may be that for some children starting out by doing that therapy in the living room doesn't work because that's just way too many distractions for the child. So that'd be fine. We'd want to start in a more structured, supportive environment, but as part of the program, you'd want to focus on moving to a naturalistic environment. As well as literature suggests that utilizing this intervention for about 25 hours a week for about 2 years seems to be an important component. And ideally, we want to start that intervention somewhere between 2 and 4 years of age, maybe even earlier. Again, the literature hasn't borne out so much yet that we want to even start earlier, but I think that's what we'll be seeing in the next couple of years is the importance of intervening even prior to 2. What else do we know about this early intervention or behaviorally based approaches? We know that it's very effective for some children, not necessarily for all children. We know that a substantial proportion of children are then able to attend regular education classes by using these comprehensive ABA-based models. We also know that the kiddos who are starting out with stronger cognitive abilities seem to respond better, are more likely to respond more quickly to that ABA-based approach. Unfortunately, that's kind of the limit of our understanding at this point of what interventions are effective for which children. Certainly at the ABA level, we know that, well, gosh, if the kiddo starts out having a pretty strong cognitive ability, that he or she's going to respond pretty well to the approach, but we don't know much more than that. We do know that when early intervention is implemented, we know that those gains are stable long into adolescence and into young adulthood, and we know that it's cost effective. Even though ABA-based treatments are very expensive in the moment, it's actually a lot cheaper to intervene earlier than to focus on intervening later. So a lot of this information comes from a great review that was published last year by actually another one of the Simon Simplex Collection investigators, Zach Warren at Vanderbilt, the lead author on this paper published in Pediatrics. And what Zach and colleagues did were they conducted a comprehensive systematic review of all treatment intervention studies focused on autism that were published between 2000 and 2010. They had certain criteria they needed to limit. That is, they focused only on papers that were published in English. They focused only on studies that included a medication trial where there were 30 or more participants, and if it was a behavioral or a complementary and alternative medicine approach, they included in studies where there's more than 10 individuals. And there, the idea is you want to make sure that the sample is large enough to draw some conclusions about how effective that is for all children with autism. And they focused on treatments that were similarly relevant to autism specifically. What they did by looking at this comprehensive review of the literature is they identified there was 159 unique studies that looked at interventions in autism. And then they rated them in terms of quality. This is the part where I get a little bit nervous as a scientist, and I think, gosh, wow, of 159 studies, only 13 met sort of that good quality characteristic. And let me just tell you about how they made that decision. I think this becomes important for us as consumers of the literature and consumers of what's reported in the media. We want to understand, well, what in fact does make a good quality study. So for Dr. Warren and colleagues, how they defined a good study was had to have a number of different criteria. One was they wanted to look at the study design. They needed to make sure that there's going to be, in each study, that there's going to be a comparison group. So not only the individuals that were getting the treatment, but also another group of kids or individuals that were getting either a different treatment, ideally, or not another treatment. And they wanted to make sure there's random assignment. So of the 20 or 30 people that participated in the study, essentially with a flip of a coin, there needed to be a decision, would the individual get the treatment of choice, experimental treatment, or would they be in the comparison group? And that, of course, is to make sure there's no systematic bias into who gets into what group. We could imagine that if a number of families are very excited about one particular treatment, for whatever reason, and they say, well, I'd like to get that sort of treatment, there'll be a bias that it might work or seem to work better for those families who are engaged in participating in that treatment that they believe is going to work. So by random assignment, we kind of rule out any of that systematic bias. And we need to have that comparison group to make sure that, well, the changes that are happening are really due to the intervention itself, not just, well, as children age, they seem to improve, or it's not something in the air, so to speak, something else that's impacting and showing improvement for the children. That was one thing. They also looked at how accurately described and how clearly diagnosed the children were for the study. So we want to make sure that the children that are participating in the study, in fact, have a diagnosis of autism. So there was a criteria around how clear that diagnostic procedure was utilized. Were there specific measures that were used, like the Autism Diagnostic Interview and Autism Diagnostic Observation Scale or Schedule, or did the scientists use DSM criteria, or did scientists not really focus on that and just say, well, the child came in with a diagnosis of autism, and we seem to think that was right. So looking at how clearly diagnosed the participants were. As well, there needed to be a clear description of how the participants were ascertained. Were there clear inclusion or exclusion criteria? And that becomes very important, right? So if it's a study on autism, we want to make sure that the scientists aren't excluding, well, we exclude every kiddo with autism who also had a comorbid intellectual disability. Well, that's a very different story than a study that includes all individuals with autism, or all individuals with autism who have an IQ over 120. These are very different types of studies. You want to make sure that these exclusion criteria and inclusion criteria are very clearly laid out. As well, anytime you're doing an intervention study, you want to understand the attrition. Is there some sort of variation into which children drop out of the treatment? If you're doing a 2-year intervention, you want to make sure that that you're comparing the 24 children that started at the beginning of 2 years with the same 24 children at the end that completed that 2-year intervention, as opposed to looking at 24 children that started and only 4 complete that 2-year intervention. We want to make sure that's clearly described and understand. We have to understand that attrition. Obviously, it's not a very good comparison if you're looking at 24 to start and 4 to end. Also, well, what happens with those other 20 individuals? We have to understand that. As to be described. And in fact, if there are any individuals that drop out in any intervention, they want to compare those kiddos that dropped out. How do they differ from the kiddos that stayed in? Because it becomes an important piece. So making sure that's described in the study also is one of the criteria used for this. Additionally, just the characteristics of the intervention. So the intervention needed to be fully described. That is, what was the dosage of the medication, or what was the timing of the intervention? How old were the children that participated in the intervention study? How long was the intervention? What was the intensity of it? Was it 25 hours a week? Was it 3 hours a week? How faithful were the practitioners or providers to the manualized treatment approach? That is, if it's a school-based intervention, were the teachers all following the curriculum in the manual, or were they kind of doing their own thing? That fidelity is important. As well as how closely did the participants adhere to the treatment. If it's say for example, if it's a study on diet, well, how faithful were the children to maintaining that diet, that specific diet? The last couple factors in thinking about how to evaluate the research study that Warren and colleagues used was looking at outcome measurements. So were the outcome measurements, were they appropriate? That is, after 2 years of intervention, what things were we looking at? Were we looking at attention skills? Were we looking at cognition? Were we looking at language ability? Were we looking at motor ability? And not only just what the measure was, but how relevant was that to the treatment? Did it make sense? Was there some sort of link, theoretically, as to why the scientists chose to look at those outcome measures? And I think most importantly is, were the people that were using those outcome measures, were they blind to intervention type? That is, if we have 2 groups, one group getting an intensive behavioral intervention, another group getting a medication treatment, we want to make sure that whoever's doing those outcome assessments doesn't know if the group was in the behavioral treatment or the medication treatment, because there can, again, be some slight bias that even the experimenter doesn't realize. The experimenter might think, gosh, I really think this medication is going to work, and so it turns out that he or she then sort of, oh, well, you know, on this scale, this kiddo seemed to do a little bit better. And certainly that becomes really relevant if it's a study where the scientist is being funded by a particular pharmaceutical company. You want to make sure that really those scientists are blind as to subject group, because there becomes a significant bias there. Lastly, is one of the criteria that Warren and colleagues used was looking at the statistical analysis. You want to make sure that the stats that are reported are accurate and effective. Really, stats can tell us lots of things, and you plug in the right numbers, you can sort of paint a lot of different pictures with the same sort of data, and you want to make sure that you're analyzing those numbers actually very clearly. What do they really mean? Do the numbers really mean what the scientists say they mean? So based on those criteria, it turns out that in 10 years of research in autism intervention, there were 13 studies that actually met all those criteria, meaning good quality criteria. There were 56 that met some of those criteria, but not all, and then almost 100 that really were doing pretty poorly and that were not meeting many of those criteria at all. With that limitation, there were a number of conclusions that can still be drawn. One of those conclusions is that, as I mentioned, risperidone and I can never say aripiprazole. See, I'm a psychologist, not a physician, but those two antipsychotic medications clearly have shown multiple times that they're improving those challenging behaviors, such as aggression and self-injurious behavior. But there are significant side effects. Some of the side effects include significant weight gain and such. So those things have to be weighed out. I'll talk about that as well when we talk about how to evaluate interventions and medication usage. The other important thing to note about the medication trials is that these medications aren't addressing the social communication impairments in autism. Really are focused on those challenging behaviors. Other take-home messages from this review study: those early intensive behavioral interventions, such as the Discrete trial training model or the Lovaas method, or DTT, however you want to talk about that, or the early start Denver model, both those seem to show significant support for improving cognition, improving language skills, as well as adaptive behavior. Adaptive behavior are things like daily living skills and being able to communicate, engage, and just kind of make it through your day. Other promising approaches are cognitive behavioral therapy that are focusing on social communication and other challenging behaviors. So for specifically, there's a nice approach that's been developed down at UCLA by Jeff Wood using CBT, or cognitive behavioral therapy, for addressing anxiety, and specifically in children with autism. That seems to be showing some significant promise. As well as parent training clearly augments treatment outcomes. The best outcomes are those are in response to those treatments where there's a parent training component where parents are significantly involved. The TEACH method, TEACH model, which I'll just talk briefly about in the next slide, seems to show is a model that shows improvements in cognitive ability as well as motor functioning. But the take-home is that there's little empirical support for any other treatments besides those treatments I've just mentioned there, and that includes all of the complementary and alternative medicine treatments. That doesn't mean that they're not effective. It just means that the science hasn't been able to evaluate that effectively or answer those questions more concretely. Given all that, we still don't know several things. We still don't know what treatment is most effective for each individual. So we have no idea yet how to pair our particular treatment approach with a particular child or particular family. We still don't know specifically how well these behaviors generalize to outside the research treatment context. Again, most of the outcome measures are measured in a standardized setting, like a university-based assessment clinic, and that's where the assessment outcome measures are often made. So we don't know how well those skills are being utilized in the school or elsewhere. And we don't know which specific components of some of these models really are most effective. So for example, the Start Denver model, we have a focus on, it's a naturalistic model, it's a developmental model, it's behaviorally based, it focus on different areas like attention, affect. We're not exactly sure which specific component of all of that is actually the most effective piece. similarly, we don't know which things modify the effectiveness. So say, for example, risperidone seems to be effective for many children. We don't know what modifies that. We don't know if there's certain child characteristics that might make a particular child more responsive to risperidone than to others, or other factors. Are there other factors such as like the teacher's skills, or the behavioral, the BCBA's ABA skills? Is that really kind of a significant modifier, or is that less effective than the actual treatment model itself? We just can't really answer that. Of course, intuitively we think, well, of course, if you're a good clinician, it should help out, but we actually don't have any science to actually answer that question for us yet. So, just want to highlight just briefly just the TEACH model, because we didn't talk about that earlier, but so the TEACH model was originally developed back in the 60s at UNC, University of North Carolina, by Eric Schoppler, and this model is originally called TEACH model, the treatment and education of autistic and related communication handicapped children. And kind of the major premise of this model originally started with by physically modifying a child's learning environment by providing additional visual cues, the use of important schedules, and additional supportive structure that's really going to help and improve outcomes for children with ASD, and over the years, and certainly based on this review, that this approach seems to be very effective for improving cognition, but not only cognition, but also motor skills for children with autism. Just want to highlight that model. The other thing I wanted to highlight, just getting back to this notion of complementary and alternative medicine, while the literature isn't suggesting necessarily that these approaches are highly effective, certainly that doesn't mean anything yet, I would say. I would say that the jury's still out. But the other thing I want to highlight, and this is based on data actually from all of you, from participants in the Simon Simplex collection. This is work that was done by a graduate student focusing on just who utilizes complementary and alternative medicine, how frequently, and are there any factors we can look at. So based on the Simon Simplex collection data, it turns out that almost 3/4 of all family members, 3/4 of all families report using some complementary and alternative medicine approach to address behavior at some point. So that could be using a dietary approach, DSCF diet, or vitamins, or any of the other countless approaches I listed on that previous slide. So clearly, these are approaches that are being used quite regularly. The science needs to catch up. We need to understand, well, what's going to be most effective and what's going to be most effective for which children. It also turns out that the families that use these complementary and alternative medicines, that's actually tied into certain characteristics of children. It turns out that children who seem to be more impaired with autism symptoms are more likely to utilize alternative medicine approaches, as are children who are more cognitively impaired. So this little figure here I've got on the right side of the slide, on the bottom it shows autism severity using a calibrated severity score, which is a metric based on clinician observation of how severe, that's in quotations, I'm using air quotations which you can't see right now, but how severe is the child's presentation of autism. On the left side, we've got just the amount of complementary and alternative medicine use, or CAM use. So as you can see, as we go from left to right, from less severe down on the left to more severe on the right, we can see that the use of complementary and alternative medicine increases pretty dramatically for children with autism. In fact, families are twice as likely to use a complementary and alternative medicine approach if the child also has a comorbid intellectual disability. So all this is to say is we need to understand CAM use. We have certainly a lot of folks are utilizing complementary alternative approaches, and the science is able to answer some of those questions. So given that we don't really know a lot about what science is telling us about CAMs, these complementary alternative medicines, how do we consider these? How do we think about these? How do we evaluate these as parents and as clinicians reading the literature? So here's a little guide that I really use quite a lot and think about it in my clinical work when talking with families. And so I've got a little grid here. On the left, we have on the y-axis we look at how safe a particular intervention is. So on the bottom we'd see is there's limited evidence that it's a safe approach. At the top, there's more evidence that it seems to be safe. On the x-axis there, going from left to right, we think about how effective the intervention is. Is there limited evidence that this intervention is effective, or as we move to the right, there's a lot of evidence suggesting that this is a very effective intervention. So when hearing about a new intervention, whatever it may be, someone says, hey, I've got this new approach. You know, I'm advertising at 3 in the morning on the Home Shopping Network. Here's my approach for autism. Let me tell you about it. What I want to do is I want to do a little research on it, and I want to find out about, well, how safe is this approach and how effective it is. And then I use this little grid to kind of evaluate it. So, for example, looking at the left column of this little grid and upper left column, if there's an approach that seems to be safe, there doesn't seem to be any evidence to suggest that it's not a safe approach, but yet we don't know how effective it is, then I would say, sure, I think we should try it out. I'm going to go ahead and tolerate that approach. I'm going to be cautious about it. I'm really going to monitor how effective it is for my child. A good example might be here for many of these complementary alternative medicine approaches. So, for example, the GFCF diet is a great example of a diet that doesn't seem to be unsafe. We have to be monitoring that in terms of in the context of nutritional needs for a child. But the scientific evidence doesn't suggest at all that that it's an effective approach for children with autism. But that doesn't mean that it may not be effective for a particular child with autism. So therefore, again, that goes in that upper left column, upper left quadrant for me. I'm going to tolerate, we're going to use cautiously, and we're going to monitor how effective is this intervention, dietary intervention for my child. Also in the left column, another example might be something with limited safety. We know that chelation therapy is quite an unsafe approach. In fact, a few years back, a young child with autism died after receiving a dosage of medication as part of chelation therapy. And there's actually limited evidence of effectiveness for it. So that sort of chelation I would stick in that bottom left quadrant. So the perfect thing we want, of course, is something that seems to be safe and highly effective. So at the upper right-hand quadrant, those are the kind of treatments we're going to recommend. We're going to still monitor. We want to make sure it's effective for our child, but we go ahead and recommend that. Those would be things like ABA-based principles, or if it's we have a child with significant self-injurious behaviors and aggression, we might consider particular medications that may or may not work. That may work, but that may have side effects we want to, again, use cautiously. Actually, a really good example of the medications would be in the bottom right-hand quadrant. So, again, for self-injurious behavior, we think about risperidone, which has some significant side effects regarding obesity and weight gain. So we might think about that limiting the safety of that medication intervention. So we might put that in the bottom right-hand column because it seems to be very effective, but there are some questions about how safe it is. We might, again, consider using it because we've got a significant problem like self-injurious behavior, but we want to be using that cautiously. So that's just a little grid I just like to highlight because I think it's an important way to think about interventions. And lastly, in just the last couple of minutes, I want to just whip through the next 3 slides just to think about some questions we could ask when presented with intervention. So we can think about it using this guide, but also when presented with specific treatments, these are, I think, some questions we just want to ask. And this is based on a paper that was published way back in 1997 in the Journal of Autism and Developmental Disorders. But really highlight just these specific questions. Will the treatment result in harm? Big first question. Does it seem to be developmentally appropriate for my child? How will the failure of the treatment, how will this affect our family? Are we putting all our eggs in this basket, or are we thinking about this in kind of a somewhat emotionally detached way, if that's possible? Has the treatment been validated scientifically, as we've been talking about today? And also, how will this new treatment be integrated in the child's current program? Are we just going to toss out the old program we've been doing with our child, or are we going to try to integrate that with what we're currently doing? Other questions to ask, or other sort of guidelines to think about, would be to approach any new treatments. I think this is a nice way of thinking about it, with hopeful skepticism. But also, we should be aware of any treatment which states, and these might be the treatments we hear about 3 in the morning in the Home Shopping Network, that it's appropriate for every child with autism, because gosh, no one knows that. Every child with autism is unique and different. It brings their own strengths and challenges. So I'm gonna, anytime anyone says, "Oh, this is appropriate for every child with autism," I kind of, my eyes glaze over and I sort of zone out at that point. Similarly, be wary in treatment that supports individualization, sort of similar to that. And also just keep aware that there's all these treatment options out there. And so any treatment that is suggested to you, promoted, or recommended, it's one of many different options. Think about all those. Lastly, the last few, it's important to know that any intervention, you want to start following a careful assessment of the child, which suggests that that particular intervention is appropriate. So if someone says, hey, I've got this great intervention, it's called reciprocal imitation training program, we're going to focus on it for your kiddo with autism, that's going to be great, but yet you have an independent evaluation that actually suggests that your child with autism seems to actually do pretty well in imitation. You might sort of wonder, gosh, this might not be the appropriate intervention for me. Again, also we want to make sure that any intervention is any proposed treatment, it's clear what assessments are needed to find out if that's going to be an appropriate intervention for them. And then, kind of as we've been chatting about a lot today, many of these treatments haven't been validated scientifically, so you really want to think about all these new treatments within the context of that grid. And lastly, that lots of discussions about treatment can end up in superficial arguments. And I think it's because it's a heated topic to figure out what's going to be most effective for your child. So I think, again, trying to have that hopeful skepticism and that slightly detached sense about how we're going to evaluate how effective this intervention is for our child and how appropriate it is. I'm going to do that. So in the last 20 seconds, I just want to say briefly what I think we can look forward to in the future when thinking about intervention in autism. And by future, I mean 6 to 18 months time. I think there's going to be a much stronger focus on understanding how parents are the most effective interventionists, and so we need to think about evaluating that and providing good guidelines and structure for how that can be most helpful. As I mentioned, CAM use is one of the, by far the most common sort of category of treatment approaches that are utilized, but yet science is kind of behind the times on that. But we get it as a field, so we're working on understanding the effectiveness of many of the CAMs that are used out there. Use of technology is certainly a hot topic among lots of folks, incorporating iPads and the Microsoft Connect and all these different technological advances that have been made to incorporate that into intervention programs. And really more recently, interventions that are tied to specific gene functions and disruptive proteins. We're learning so much more about the genetics of autism in large part due to the Simon Simplex collection. And so we can identify what genes are disrupted, and well, we know what genes do. They just make proteins. They don't make behavior, they make proteins. And so we can think about, are there medications that we can develop that target those specific proteins that seem to be disrupted in autism. So I think that's what we can expect to be looking forward to in the future, and really in the very near future we'll start to think about some of these interventions that will be sort of hitting the media and scientific literature. So given that, I want to say a real hearty thank you to all of you for your attention today, but also for your participation and involvement in research. Obviously, none of this can happen without all your effort and all your time, and in many cases, a lot of your blood. In fact, actually, I just want to say a big thank you to that, and our last several minutes here, just want to be able to respond to any questions that might arise or might have arisen over the course of the talk. Thank you.
Thanks, Rafe. This is Casey back again. Great presentation, very thorough. It's a wonderful overview for everyone, I think. I do have a few questions for you in our last 5 minutes here. I'll start out with one that was from closer to the beginning of your presentation. So you talked about how to figure out the motivations for behavior, what happens right before or right after a behavior that you want to try and work on. This parent has a really hard time sometimes determining what is triggering their child's tantrums at home, and wonder if you have any suggestions for helping them to figure out what's happening and what's triggering the unwanted behaviors.
Yeah, well, that's a great question, and figuring out kind of what the motivation is for any given behavior, whether it's going to be a tantrum or trouble sleeping or whatever the behavior is certainly not an easy 2-second fix, and so my heart goes out to that family sort of with that struggle, because there is no easy answer. If I had an easy answer, I'd be psyched and I would totally throw it out there. But I think some of the things you could think about would be thinking about. One way to think about is what is the consequence of the child's tantrum? What does the child seem to be getting out of the tantrum? Is the child getting out of some behavior or something that he or she does not want or like? Is the child getting more attention? Is the child getting, so that's kind of one of the two first things to think about is, well, what happens when the child tantrums? What's the outcome? Because if there's a way to get to that outcome without the tantrum, well, gosh, that might eliminate the tantrum. So like, a good example would be is kiddo doesn't want to go to bed, for example, and you don't really know that, child isn't able to communicate that, but it seems to happen that, gosh, every night right after dinner, for about 30 minutes, the child just tantrums, and what ends up happening is the kid stays out of his or her bedroom until for another 30 minutes because the child's tantruming. You can sort of think about the consequences of what that behavior does, and that helps you think about, well, gosh, can I feed that? Can I have the same outcome without the tantrum, and can I work that in somehow, or can I change things around a little bit so I'm, again, not reinforcing that behavior? That's one way to think about it. There's really a lot of different ways to think about it. Another one that comes to mind real briefly is what am I doing as a parent to reinforce this behavior that I don't even want to do? Again, I think about this all the time, and myself as a parent is when my daughter's doing something that I'm not particularly happy with, I think, well, is there something I'm doing that's promoting and continuing that behavior without even being aware of it? Again, am I somehow reinforcing that behavior without wanting to? And so, again, trying to understand what it is, what's the outcome, what is the child getting out of that behavior, and then thinking about if you can feed that in and resolve that some other way. That would be my quick 2-second answer to a very, I think, a very long, complicated, detailed, and challenging issue.
Absolutely. All right. So for this family, and I imagine this is somewhat common as kids enter school, they didn't receive a diagnosis until their child was already 5 years old. So they missed out on the time period for early intervention, and they're wondering if there's anything they can do to catch up or anything that's recommended as a starting point for a child who's had no prior intervention. And I imagine, as you have said, this depends somewhat on the individual child. So with that caveat, that is the question.
Yeah, well, that's a great question. You know what? And that question is a question I hear a lot. So to the parent that asked this, you are not alone in asking that question. I think it's a very fair question because you hear so much in the literature and the media, and me just saying, gosh, we intervene, early, that seems to be better. Well, and that seems to be generally true. We don't exactly know how that works for every particular child, though. So for a long time, this is kind of a goofy example, for a long time the thought was if children weren't exposed to language very early on, that they actually could never develop the ability to speak, and these were cases of significant deprivation for children who were hardly neglected or locked away for years without having been exposed to language. And it turns out that was the thinking for a long time, but many of these, not many, but many kids, even when significantly deprived of language, again, this no relation, this is just another example, but it's really not tied to autism, end up developing language. So science for a long time was saying it can't happen, but yet it turns out many kids are able to develop language without having had that exposure early on. So if we think about that in the same analogy as science is saying, oh, it's best to intervene early, but science doesn't really know. Again, it really is going to be specific to the child. And also, there are other things that we know we can do. We know that even if we're intervening after age 5, we know that helps outcomes. The original studies by Lovas in the 60s, he was using discrete trial training with individuals who were school-age children and teenagers. So, and he was intervening at that level, at that age, and we're still improving outcomes. So, we know the early literature suggests that we don't need to be just intervening all the time early. We know it can be effective for older kids, but we seem to know it seems to be most effective for young kids, but that doesn't mean that it's not effective for older kids. So I'm hoping I'm in sort of inducing some measure of hope, because I think science doesn't know it all yet, and even that what literature is suggesting is that intervention is effective even after those early years. And you're not alone with that question for sure.
Perfect, thanks. We've had a couple of parents interested in specifically the parent training that you've mentioned, or if there's a training model that's preferable. If you can elaborate for just maybe a moment on that, or give them an idea of where they could look to find more information, perhaps.
Sure, for sure. So a lot of these comprehensive programs, so like PRT, like ESDM, now are incorporating a parent training component where the behavior analysts sit down and as part of the treatment program, sit down with families and say, these are the things we're working on. This is how we do it. We'd love to have you be involved as well, and we'd rather have you guys be the treatment providers because you're with your child 100%. You know your child better than anyone else. And so if you're utilizing some of these skills and working on some of these same skills that we're working on in therapy, that we're going to improve that outcome. So the parent training component really comes from a lot of this is university-based treatment programs. So like ESDM, a lot of that work is being done here at UW and then Neuroscience Institute in California. In PRT, a lot of that work is being done at UCSB in Santa Barbara. Certainly at those university-based settings, there's parent training that's going along with those comprehensive models. Other sort of training, approaches like social skills training, the peers model that's based at UCLA and some other programs around the country. A lot of those social skills training groups also have a corresponding parent training group. So while the kiddos are in group doing their fun conversation pong activities and learn social skills, parents are learning how to help augment those that skills training. So that's where another component of parent training comes in. Trying to think of the best way to connect with parent training components. I sort of wonder, I haven't checked now, but I wonder if Autism Speaks on their website, because they have a pretty comprehensive website in terms of directing folks to behaviorally based treatment providers in their area. I wonder if that might have a parent training or a directive for parent training opportunities as well. But certainly any local program, any of the SSC sites themselves are most likely going to have either a parent training component program underway or can be able to refer you to an ongoing parent training component.
Yeah, and that's an excellent point. Actually, Mrs. Stanley should all have a link to one of their SSC sites at least. So that's great to point out. I think we have, well, essentially we're out of time. Let me wrap up with this one last question, because I think that it's probably one that many parents have. So this parent sometimes has difficulty knowing if intervention is really working for her child. Some weeks it seems like we're making great gains, and other weeks it seems like they're back to square one. How can they understand if an intervention is really helping their child to make progress? How can they help to evaluate that?
Yeah, that's a great question. Certainly, I think one of the things that that literature has been telling us is we do a lot of assessments with children with autism, and a lot of the work that's being done with now younger siblings of autism is we're seeing that really that the pattern and trajectory and development of behaviors seems to be kind of marked by sort of fits and starts, really. We don't seem to see sort of a smooth developmental trajectory of skills sort of being learned and then maintained. We see a lot in many children with autism, kind of up and down. I've got a skill, oh, it's sort of not singing anymore. Oh, we've got a skill, it's kind of dropping down. We're seeing, you know, an upward trajectory, but it's just a lot of hills and valleys in that process. Really, I think the only way to truly evaluate that is to really keep good data and good records, and that's kind of why I think the behavioral-based models are effective. So for focusing on developing a skill, we're going to track that in the short term. Has Joey developed a skill? Yes, we've seen him demonstrate it in that setting and this many times, and we're deeming that's effective. Periodically, it's important to kind of go back. Many interventions we'll do is we'll go back and check in on those skills that have been mastered just to make sure that they're being maintained. And by doing that over the long term, you can start to think about how effective sort of an intervention approach is going to take. It's hard because we want to sort of be able to move more quickly, right? Because we're like, oh, we want to master skill, we want to move on to the next, we want to try to do this as quickly as we can. But sometimes understanding truly if it's effective, it takes time to kind of sit back and look over the course of a chunk of time, a few weeks. Have we a few months, have we developed this skill for real? So sometimes it means just taking a step back and evaluating the data over the course of the long term, as opposed to just this week we're focused on this behavior, and gosh, Jill's got it now, but we want to make sure that that's truly the case, because we might see some of that sort of loss and gain later. So I know it's not a super satisfactory answer. I wish I had a true good sort of silver bullet answer to that, but I think the true answer is that there's fits and starts, and it sometimes takes sort of stepping back and looking at the data over the long term to make sense of it.
Absolutely. Well, thank you so much, Dr. Bernier, for your time and for answering the questions and preparing the presentation. Really do appreciate your time. I also wanted to thank everybody who joined for listening in, and we will be in communication with you once the link is posted. And of course, for our next webinar, we will let you know as soon as we get it scheduled. Thanks everyone for joining, and have a great rest of your week.
Thank you, Casey. Bye, everyone.